I am a research fellow and psychologist at the Manchester Centre for Health Psychology at the University of Manchester, but actually all my funding comes from the National Institute for Health Research. I work as one of their research design service advisors, so if you're putting any grant applications in the future for fellowships or PhD funding or anything like that, or just general grants, you might get through to me as an advisor. And also the research that I'm doing at the moment is funded by NIHR. The paper that I've been asked to, the piece of work that I've been asked to talk to you about today is about patient-reported outcome measures in the NHS, and the paper was evaluating the evaluation and explaining missing data. So what I'm going to talk to you about is a little bit about, I'm guessing this is just from the speakers we've already heard, this is a really diverse range of audience members with different academic disciplines. So I'm going to talk about what PROMs or patient-reported outcome measures actually are, and explore the way in which that is very much embedded in mixed methods design in terms of the PROMs methodologies. And I'm going to talk a little bit about some of the missing data that's being seen within the NHS PROMs initiative, and then talk about our study and how that fits in and how it works in a mixed methods approach to explaining the missing data that we're seeing. And I'll be able to talk a little bit about what mixed methods has been able to add to the picture, to the national picture, and just give a little bit of summary. So everything I'm going to talk about today is in this one particular published piece of work. So the DOI number is at the bottom there. So if anybody's particularly interested in the detail, it's really easy. It's an open access publication, so you can go ahead and get hold of that. So patient-reported outcome measures are usually very short questionnaires. They're self-report completed by the patient. They're often condition specific, so they might be asking questions that are about activities of daily living, symptoms, functional status, and perhaps some well-being questions. But these are often very closely linked to, for example, the sort of symptoms and experiences that a diabetes patient might expect to have, or somebody who's got arthritis might expect to experience. They sometimes are generic in nature, so they might encompass a more multidimensional approach to quality of life or well-being, and they might have questions about not just physical functioning but psychological functioning, social functioning, spiritual well-being, and a number of other different domains. They're increasingly being used for informing healthcare practices and management, and PROMs have really come into their own in the last sort of 10 to 15 years. They can be used at a holistic individual level in a discussion of patient needs. So the patient and GP or healthcare practitioner can talk about patient treatment preferences and treatment plans. They can be used at a more organisational level to inform best practice, to evaluate effectiveness or cost effectiveness of different approaches and treatments. And they can be used at a more national level as well, for comparing relative clinical quality of providers. They can be useful, provide useful information for managers and commissioners in regard to benchmarking their services, and they can be used by regulators, policymakers. They can be used for clinical audit. So there's a lot of use for these little patient-reported outcome measures. So developing PROMs is, in the gold standard and mixed methods process, it's usually bottom up, starting with qualitative interviews and focus groups with lay people, so either people with the particular condition of interest or people from the general population, if it's a generic PROM, are asked what's important to them, what things might affect their quality of life, their well-being. And their words and phrases are used to make meaningful questions and to make meaningful response options or scales. So you'll all be familiar with the Likert scales. You know, how much do you agree with the following statement? Strongly agree, agree, not very much, somewhere in the middle, disagree, strongly disagree. But those anchors or labels can often change with different things, and it's about working with patients or lay people to find out what's meaningful for them and what meaningful answers might be. And we do think aloud studies as well, or cognitive debriefing, where people sit and really talk about what they're thinking with each question, what they understand that question to mean, and where they're placing their answer on a scale. You know, what's their thought process in reaching that conclusion and that answer. After a lot of refinement and reworking of a questionnaire, it'll go forward to quantitative work. There'll be some piloting, there'll be iterations and refinement of the questionnaire, and then there'll usually be a large number of people to fill out the questionnaire, 200, 2000, where we can do psychometric evaluations using statistics, so we can work out how reliable and how valid a scale item is. And these sort of psychometric tools are used particularly throughout psychology and educational research, but in healthcare we're also interested in statistics on clinically meaningful differences from PROMs. So if I've got a 10% increase in my PROM score, has my blood pressure increased alongside that, or has my glycemic index increased alongside that? Interest in sensitivity. So if something in my life has definitely changed and we know that, does the score on the PROM also reflect that? So is it sensitive to change, and is it sensitive to clinically meaningful differences? And we're looking at floor and ceiling effects as well. So we want a lovely, nice bell curve distribution for items, with a few people endorsing the very highest option, or very strongly agree, or whatever that might be, and just a few people endorsing the lower item, so not very happy or disagree strongly, and then a good broad range of people in the middle. In 2009, the NHS adopted a PROMs initiative across England, routinely collecting PROMs data pre and post-operatively. And originally this was for 4 conditions: hip replacement, knee replacement, groin hernia repair, and varicose veins. It's now, from 2017, it's only 2 conditions, which are hip and knee replacements. They use a condition-specific PROM, so the Oxford hip score or the Oxford knee score. So they're very much about your mobility and your pain levels and things that you might expect to experience around a hip, the need for a hip or knee replacement. And a generic PROM called the EQ5D, which is a health utility index and kind of quality of life measure. I say that because this is what the EQ5D looks like. It's got 5 items which in theory assess quality of life, but there's actually no theoretical underpinning for why they've decided these 5 items represent domains of quality of life. So I don't often call it quality of life instrument, but a lot of people do. It also has a visual analog scale, which is the thermometer that you can see over the other side of the page there on the right, which is just like a thermometer. And that asks about the best health you can imagine, can you score 100, and anything down to the worst health you can imagine, you score 0. And the criticisms of the EQ5D are that it's developed in a very top-down manner, led by clinicians and researchers, which includes the content, how it's worded, how it's phrased, how it works and operates. And that's not really how PROMs, it's not really the best practice for developing PROMs. The visual analog scale in particular lacks conceptual clarity for a lot of people. So what does best health mean? And there's a whole debate around what even health means. And there's no theoretical underpinning for the dimensions of quality of life that have been included. So as I say, NHS England rolled out these PROMs questionnaires for people undergoing 4 types of surgery, and that started back in 2009. And it's a huge national initiative. And on average, there is a 76% completion rate for PROMs, which is fantastic. But it was found that missing data ranged from 0 to 70% between trusts. So some trusts were getting 100% completed data. So the questionnaires were returned 100% of the time, and the data within the questionnaires was complete. But some trusts were only getting maybe 30% of PROMs returned, and there's lots of missing data in there. And the implications for this are that non-responders may have worse outcomes. So we're not getting a true picture of the spectrum of patients who are having these operations. There may be an overestimation of positive outcomes due to the sorts of statistical analysis you can do when you've got a lot of data that are missing. And that may lead to biased conclusions about treatments and biased conclusions about service that's occurring in different trusts. So it's really important that we understand why the missing data is there and what we can do to eliminate that missing data or reduce it as much as possible. So quantitative data analysis of PROMs data has been used to explain non-completion. So using these big data sets that are available from the NHS Direct website, or NHS Digital, one of those, you can find it anyway. So yeah, that data has been analysed, and they found that around 25% of the missing data can be attributed to individual level factors. So people who are older, have lower socioeconomic status, who are non-white, are less likely to complete PROMs. And what we know about surveys and participation in these things, we probably could have guessed a lot of that as well. But we also know that some trusts have 100% completion rate, and it's very unlikely that there are trusts out there that only serve for operations for things like knee and hip replacements, younger, higher SES, only white patients. So obviously something is happening that some patients who we might think might not complete PROMs are completing them. So the next question is what's happening at the provider level, which might explain missing data. And that's something that the statistics that are gathered can't really tell us. And that's where our kind of mixed methods study came in. So the quantitative data does already exist. And if we took a sort of explanatory designed approach to mixed methods, we would have our quantitative data set, which might be some quantitative data we'd collected ourselves, but in this case, it's data that already exists. And then we have a need for clarification, which is where the qualitative data collection and analysis comes in. And when we've clarified the points we need to clarify, we can then look at interpreting all the data that we've got to see if we can answer those questions. So questions around missing data in the large NHS data sets, especially coupled with how the EQ5D was developed, led us to believe that a qualitative approach was needed to explore and possibly explain what was happening. We know very little information about how hospitals deliver PROMs on the ground, and we actually know very little about what patients think about PROMs, and a lot of that is to do with how some of these instruments that are being used were developed in themselves. So this study is very much mixed methods in spirit. And as I say, we took a qualitative approach to investigate individual, organisational, structural and procedural factors that could shed light on non-completion and missing data. So our methods for this particular study were multi-method. We did observation and we did patient interviews. These were all pre-operative patients because the post-operative PROMs are sent out from like a big central distribution centre, and we were interested in knowing what happens actually within the hospitals themselves. It had no funding, this piece of research, so it was very small scale, and we just worked out of one hospital with an orthopaedic unit in Greater Manchester. And we had 2 phases of data collection, one over the summer period and one later on in the year. In terms of the observation, we had 45 hours of observation time where we documented the behaviours of staff, patients and anything which we thought might impact PROMs administration. A researcher sat in the public waiting room and staff were aware that they were being observed. Differences between phase 1 and phase 2 of data collection. In phase 1, a receptionist gave out the PROMs questionnaire packs before the clinical appointment that the patient was there for. And in phase 2, a nurse gave out the PROMs during the appointment, along with surgery information and other questionnaires. In our interviews, we interviewed 34 people, and these were really brief structural, semi-structured interviews, procedural semi-structured interviews. And we asked what patients were told about questionnaires, did they complete all the PROMs, what was their experience of doing the evaluation, what did staff say to them both during and after and before the PROMs, and were there any recommendations for change from the perspective of the patient. We interviewed 14 men and 20 women with an age range of 34 to 85 years old, and 23 were there for hip surgery, 23 were there for knee surgery and 11 for hip surgery. We did thematic analysis of interviews, and that information was triangulated with our observation data. The things we found, there were sort of 5 themes that came out of the interview, which were around completion, time and timing, which is where the timing of delivery of PROMs were incommensurate with clinical appointment and preoperative assessments. Orientation, which was preparedness for the evaluation. The patient's perspective on the purpose of completing PROMs was actually really important in determining how they responded to it. The setting itself, so environmental and contextual factors that influence PROMs, such as really obvious things like being in a public space, any distractions that are going on, things like that. The measures themselves, there were issues related to limited response options, which we always get with questionnaire studies. They are what they are. Lacking comprehension about a concept, so again that really related to the visual analog scale and what does good health mean to you and how would you rate your health today. And people really commented that could make responding difficult. And there were practical issues, and this relates somewhat to setting and completion time. And this was about creating time and space for a supported PROMs completion that may enhance response rates. This very much came out of recommendations. So this was the positive to the other major themes, which might have been more negative. And when we were looking at the major themes in relation to the observational data and thinking about the larger picture that we had from the data sets, we felt that there were some refined themes which were completion conditions. So creating a more sort of a research ethics process to get somebody to buy in to be a participant research is very thorough, and people were actually told very little about PROMs, and so didn't really understand why they were needed to fill in, or even if that they had something in their little pack of information that needed filling in. So we talked about creating a more ethics style consent process to increase buy-in. We talked about the need for staff training, so confidence in staff and knowledge transfer about PROMs might enhance participant and patient uptake of completing PROMs, and a standardization procedure. We found that a lot of times staff were just covering and didn't know anything about PROMs, so making sure there was a sort of standard approach. And the other refined theme was about patient support, just sorting out things like a lack of privacy, distractions in clinic, missing data, which can cause missing data. And there were worries about a fear of missing an appointment because people were completing PROMs. And that feeds into what we came up with, a sort of national delivery strategy, streamlining the preoperative information and leaflets given, reviewing, refining, repackaging and rebranding PROMs, and make sure that they're seen as an essential part of the process. And from that, we were able to make recommendations about PROMs friendly environments. I'm not going to say too much about that because I'm conscious that I'm going over time, but lots more information about that's available in the paper for anybody who's particularly interested. So in conclusion, a mixed mode approach allowed observations to inform the context of information given in interviews and allowed triangulation of findings and results validation. Thematic analysis represented the individual's standpoint, allowing nuanced views of PROMs to be voiced and to be better understood. And this is invaluable where there's very little research, and this is where qualitative research really comes into its own. And despite the large amount of quantitative research and data that was available through the NHS databases, there's only limited ad hoc qualitative information available to explain missing data, and almost none in the context of the NHS PROMs programme. So we were, as I say, PROMs are normally developed using a mixed methods approach involving lay people, but the gold standard is not always followed, and somehow that got picked up into a national initiative. Other people on here may know something about EQ5D and may have other opinions, but that's my opinion. Quantitative data showed lots of variance in completion rates with very little information that could be inferred about why. And so we used a mixed methods approach, or a spiritually mixed methods approach, to find out through observations, pragmatic short interviews, and we were able to combine what we knew from quantitative data and turn that into procedural practical recommendations for practice.